inguinal canal. Now, musculo-aponeurotic tunnel, length 4 centimeters, extends obliquely from. Now, that pathway, it has to come from the level of the kidney and goes there, and the kidney ascends. That's why you will see in routine USGs there are report is that kidney in the pelvis or the horseshoe-shaped kidney. Don't panic, because if an adult has come with such problem, but he or she is not complaining of that problem regarding any disease related to the kidney, ureter and the bladder. But the testes comes down from the deep ring to the superficial ring, directed downwards, forwards and medially. Now, spermatic cord in males and round ligament of the uterus in females, the ilioinguinal nerve, contents of the inguinal canal. Ilioinguinal nerve branch from the lumbar plexus number 1 and enters into the inguinal canal by piercing the internal oblique muscles 2.5 centimeters below and medial to the lies superficial to the spermatic cord, leaves the canal through the superficial inguinal ring. You can see here. Now the anterior wall, posterior wall and the roof and the floor. Now see anterior wall of inguinal canal, skin, superficial fascia, external oblique aponeurosis, medial 2/3, internal oblique muscle, lateral 1/3, weakened medially due to superficial inguinal ring. Now, this is the canal. Now, weakened medially due to the superficial inguinal ring. And due to the evolution of erect posture, which I have been telling you earlier, I have told you that the elephant or a hippopotamus or large animals, a big bull, they don't usually have hernias. But human beings have hernias predominantly in males, but even females do have inguinal hernias because the round ligament of the uterus that comes down through the inguinal canal and it is in the labia majora, it is there. Now when you see any operation or when you resecting in the hall, you will see the inguinal nerve, you will see the all the structures which I have been telling you just now. Now, superficial inguinal ring, triangular gap in the external oblique aponeurosis outlet of internal ring, situated above and lateral to the pubic crest. Base, pubic crest, apex, convergence of two crura, medially superior crust attached to symphysis pubis, laterally inferior crust fixed to the pubic tubercle. You see when you dissect in the dead body, you please see, you take the pelvis with you. Pelvis, you put it beside the dead body and see and feel the pubic tubercle. You can see it because that's the point when you are doing open mesh inguinal hernioplasty, putting a mesh there, we put a suture and fix that point there. And then we place the mesh in the canal. And afterwards, loose stitches are given into the muscle, the internal oblique, external oblique muscles, and then transversus abdominis is there. And now you have to see it's like a triangle like this. The base is the pubic crest and apex convergence of two crura, medially superior crest attached to symphysis pubis and laterally inferior crest fixed to the pubic tubercle. From the margin of the superficial inguinal ring, there is the origin of external spermatic fascia. Now, fascia transversalis, the wall of the inguinal canal, fascia transversalis, strengthened in medial half by conjoint tendon. You can see the individual structures in the dead body. You can identify it because these landmarks are very important for surgery and weakened laterally due to deep inguinal ring. Now, deep inguinal ring, it's an oval gap in the fascia transversalis situated 1.25 centimeters above the mid-inguinal point. Okay, forms the inlet to the inguinal canal. Forms the margin, there is origin of internal spermatic fascia, covers the spermatic cord. Now, roof of the inguinal canal formed by arch fibers of internal oblique and transversus abdominis that forms the conjoint tendon. Now, it might be an MCQ or a question how the conjoint tendon is formed. Then you give this description along with the bony landmarks. Now, this is the transversus abdominis muscle, the arch of Douglas, and you can see the orifice of internal oblique, Hasselbalch's triangle point. This is the tendon and iliopubic band over here. Now, floor of the inguinal canal, grooved upper surface of inguinal ligament and strengthened medially by lacunar ligament. Now, now the inguinal ligament, you see, it will be like this. So over here, you can, the fibers of the internal oblique muscles, you can see aponeurosis, and you see that it is a straight line. You can just put the fascia transversalis and transversalis muscle, and you can dissect and see the total inguinal ligament there. Okay. Now, this is the grouped upper surface of the inguinal ligament strengthened by medially by the lacunar ligament. Now, defensive mechanism of external, the posterior abdominal wall pushed forwards, grouped upper surface of the inguinal ligament and strengthened medially by the lacunar ligament. The posterior abdominal wall pushed forward to approach with the anterior abdominal wall flap valve mechanism. And the anterior wall is strong laterally, but at the level of the deep internal ring, and posterior wall medially at the level of superficial inguinal ring. Conjoint tendon comes in contact with the floor shutter mechanism. Contraction of crevastic muscle pulls testes to close to the superficial ball valve mechanism. Now, these are the points like your crevastic muscle. You can see if it contracts, the testis goes up. But now Inguinal hernia, protrusion of abdominal viscera into the inguinal canal, indirect and direct inguinal hernia. Types of inguinal hernia is determined by the inferior epigastric artery. Now, the inferior epigastric artery is here. The medial and downwards, if you ask the patient to cough and the swelling is in the medial side, direct inguinal hernia. But the your laterally is indirect inguinal hernia, because your in direct inguinal hernia, now this is the gubernaculum testis. It is a peritoneal sac. It comes forward, and after the birth of the child, it collapses and gets adherent. At times, it doesn't close. So the sac, which is like a red carpet for the testes. The Maharaja comes, the red carpet, the peritoneal sac, and the testis comes in front of it. So, after birth, there's a closure forming the gubernaculum testis, and there is no hernia. But in later stage, any person can get an hernia. But in a child, just after birth, the mother, say after 3 months or 2 months, will go to the doctor and tell you, sir, you please see, there is some swelling here. And in the female even, this mother comes and shows that there's big swelling here, a small swelling here, please observe. Now what you do, in your clinical tests you can diagnose, but you're having modern investigation, best is USG. USG of the inguinoscrotal region in case of male, you prescribe, and in case of female, inguinolabial. Inguinolabial, you order for request for not an order, but you request for a USG, ultrasound, in case of female, inguinolabial. In case of male, inguinoscrotal. So you can see the picture. Now, see, modern anesthesia, modern sutures, everything, your skill. Pediatric surgeons, they are operating on children. So, or you can tell, because see, first day is operation karna hai, mother gets panicking. But there are some rules, because the baby weight has to be up so many kgs, at least not before 6 months, 1 year, 2 year, 3 year, in case of females. But there are big hernias in children, very big. So you have to intervene. You have to do your operation. Okay? Now hernial sac enters the internal inguinal canal through the deep ring. Through the deep ring, hernial sac enters inguinal canal through the deep ring. Hernial sac lies lateral to the inferior epigastric artery. Point of entry, common in children and young adults, and common in children and young adults. The direct inguinal hernias in the medial in males. Now, coverings of the indirect hernia, peritoneum, extraperitoneal fat and tissue, internal spermatic fascia, cremasteric muscles and fascia, external spermatic fascia and skin. Now, this is coverings of the indirect inguinal hernia. So you don't have to cut the sac, you don't cut because you just dissect and you take this is the sac. What you do, you lift up with a tissue forceps and you take and you do a purse string like this, like this, like this, like this, like this, like this. The ladies have purse, जो बोलता है क्या बुटिका or boutique, or it's like this. You pull the thing and you close. Very beautiful, fashionable. These purses are there, and you can. Most of you might be having one, and that you suture it and put the sac like now. If this is thing, this sac is gone inside, and it is like this. If you pull this and you push this here, then it becomes, the suture is here. Now, in case of, you can, if it's a big thing, and if you press and see if the muscles are weak, then you put a mesh. Or usually you don't need a mesh, but anyway, you put a mesh, and depending, your judgment is, you have to judiciously think of how you will manage that case. Because every, more or less, a patient is different from the other. Okay? Now, Hasselbeck's triangle, this can be a short note. Medial lateral border of rectus abdominis, yeah. Lateral inferior epigastric artery, inferior medial half of inguinal ligament, and floor peritoneum, extraperitoneal fatty tissue. This is Hasselbeck's triangle. Short note, or now direct inguinal hernia. The hernial sac enters inguinal canal through Hasselbeck's triangle. Hernial sac lies medial to the inferior epigastric artery at the point of entry. And now the medial part of the triangle in elderly males, medial and lateral direct inguinal hernias depends on whether leads through the lateral or medial part of the triangle. Here, see the direct, this is the inferior epigastric artery, deep inguinal ring. This is the deep inguinal ring. And this is the extra peritoneal fascia. And this is the superficial inguinal ring. Parietal peritoneum, conjoint tendon, and the peritoneal bulge here. Now, indirect inferior epigastric artery, deep inguinal ring, extraperitoneal fascia, parietal peritoneum, and superficial ring, peritoneal sac. Yeah, the sac, and see this part I was telling, this actually closes, and that is known as the gubernaculum plexus. But if at all this is connected, before birth is connected, and also persist, there is a sac like, but it's not contracted or closed, it's not closed. So it can be, and there can be your only a portion of the cord, this portion, and this portion is closed. So it's the encysted hydrocele of the cord. Encysted, it's like a cystic swelling in between the hydrocele. It's an hydrocele. So you have to just drain it and reverse. The procedure is usko ulta do and suture it. Now coverings of the direct hernia, inguinal hernia. Now the peritoneum, extraperitoneal tissue, fascia transversus, cremastic muscles and fascia, conjoint tendon in case of medial direct hernia, external traumatic fascia and skin. Now rectus sheath, the aponeurosis which envelopes the rectus abdominis muscles. This is the rectus abdominis muscles. Situated on each side of the linea alba. This is the linea alba. Anterior and posterior walls, medial and lateral margins. Here, orientation of the rectus sheath. Now, above costal margin, see the muscles, and between costal margin and arcuate line, when you dissect the body, you will see it. And below arcuate line, this position. Anterior wall of the rectus sheath, above the costal margin entirely by the external oblique aponeurosis, between the costal margin and midway between the umbilicus and symphysis, external oblique aponeurosis, anterior lamella of internal oblique aponeurosis, from previous extent to symphysis pubis, aponeurosis of external oblique, internal oblique, and transversus. So it will be, you will just beautifully, all the dead bodies are good. You dissect a part and see for yourself. And now posterior wall of the rectus sheath, above the costal margin, wall is deficient. The rectus abdominis rests on the 5th, 6th and 7th costal cartilage. Between the costal margin and midway between the umbilicus and symphysis pubis, the posterior lamella of internal oblique aponeurosis and transverse abdominis aponeurosis. Below the arcuate line, thickened part of fascia transversus iliopubic tract. Now, the medial and lateral margin formed by the linea alba extends xiphoid process to symphysis pubis. Now, linea alba can be a short note. Now, lateral margin formed by the linea semilunaris extends from tip of 9th costal cartilage to the pubic tubercle. Now, contents of the rectus sheath: rectus abdominis muscle, pyramidalis muscle, superficia, inferior epigastric vessel, branch of the thoracic artery, internal intercostal artery, branch of the external iliac artery, lower 5 intercostal nerves, T7, 11 and subcostal nerve. Now, rectus abdominis muscle, long strap muscle situated in the middle line. Origin medial head arises from the anterior surface of the symphysis pubis. Lateral head arises from the pubic crest and pubic tubercle. Insertion by 4 fleshy slips. Medial slip attached to the xiphoid process and lateral slips attached to 5th, 6th and 7th costal cartilages. Nerve supply 7 to 12.